Okay.
Is it on now or no?
Yeah, it is.
Oh.
Andrew, do you have enough memory?
Sorry. I'm so sorry.
Were we done? But like, was it clear for you and lay down?
Alex, back where you're sitting, can you hear me okay? Can you hear me okay? What? Yes? Okay. I turned the mic down a little bit to try and get the audio right. If by some chance you don't hear me okay, let me know. Okay, so the way I'm going to do this today is I will primarily, I will focus on neck. So I'll go through things that I might think are important. I probably wrote 20 questions for the neck, so I might know what's important. If I don't cover something, you can probably read into that. I hope so anyway. So just pay attention, and we should be good. Hello, those of you out there in recording land. Hopefully this will help. Okay, so let's get going. We'll do this and then we'll get the models out for anybody who wants to stay and spend more time with the models. Okay, so all this stuff at the first, remember, this is not stuff that's going to be tested specifically on the test. This was stuff for, getting everybody on the same page going forward. So skip through all this stuff. There was some important information in there that will help you, but don't worry about any specifics. Okay, so moving along. All right, so it's going to be important for understanding about the fascial layers. You should make sure you remember, as I described it, what structures are found within certain fascial cylinders, and then specifically fascia relative to anterior and posterior triangle. So as I went through, remember I said platysma was in the superficial fascia, but then two muscles were involved with the outer investing layer of the deep cervical fascia, that being sternocleidomastoid and trapezius. Those two muscles are directly enveloped within that fascia. So if there was a question, which of the following muscles is located within the outer investing layer of the deep cervical fascia? There were 5 muscles listed. You're looking for sternocleidomastoid or trapezius. Okay. Then next, for the prevertebral muscles, which muscles would be encased within the prevertebral fascia? Well, those 5 muscles that you learned relative to that posterior triangle. So splenius capitis, levator scapulae, and then the 3 scalene muscles. Those are prevertebral muscles that would be within the prevertebral fascia. We then talked about how we have something called the visceral fascia. The visceral fascia encompasses all of this viscera of the neck right here. And so what it does is it's anteriorly, or really for about 3/4 of its pattern, it's subdivided into pretracheal, this in blue, and then in green is the buccopharyngeal. And together they form the visceral fascia. The visceral fascia encasing things like the thyroid gland, trachea, esophagus, those structures. Recurrent laryngeal nerves being there, I wouldn't worry so much about that. Viscera of the neck. Then the 2 carotid sheaths on each side. You need to know there are 3 and only 3 components inside the carotid sheath. It would behoove you to know that the internal jugular vein is lateral, the common carotid is medial, and the vagus nerve is posterior, kind of in the middle between the 2. So lateral, medial, posterior. Okay. We'll learn much more about platysma when we do the neck, when we do the face, because it's also going to be kind of a muscle. We include in the muscles of facial expression, so I wouldn't worry so much about platysma at this point. All right, you do need to know the boundaries of the triangles, not so much in the laboratory, but for the test. So it's important to know the big triangle itself versus the smaller triangle, the sub-triangles. So make sure you know the boundaries of the triangles. Until we don't always do boundaries, but for the neck it's important because it also ends up being a lot of board type things. So we're doing posterior triangle of the neck first. You know the big triangle is trapezius, sternocleidomastoid, clavicle. And then what do we use for the sub-triangles? We'll put inferior belly of the omohyoid into place to separate it out into two sub-triangles. I know I've got a slide coming up about that, but again, trapezius, sternocleidomastoid, clavicle for the entire posterior triangle. Then put the inferior belly into place to subdivide posterior into two sub-triangles. And we'll talk more about anterior cervical triangle in a little bit. Anything on this slide about sternocleidomastoid, make sure you know its origin, know its insertion. People oftentimes get it mixed up. Make sure you know origin is sternum clavicle, insertion is mastoid process of the temporal bone. So this is its origin, this is insertion, because what are we trying to move? We're trying to move the head, the skull basically. All right, we're not trying to move sternum and clavicle, we're moving the head. Make sure that you know that it's innervated by cranial nerve 11. Only two muscles are innervated. Cranial nerve 11 is a purely motor nerve that innervates two muscles, sternocleidomastoid and the trapezius. I'll show you this slide in a minute, but you're going to be able to tell in here cranial nerve 11 because you can see it come out from, it won't come out at Erb's point, it'll come out higher, and it's going to travel across the posterior triangle and then disappear deep to trapezius. Typically, motor nerves are located deep to the muscles that they innervate. There's exceptions to that, but for the most part, it's deep. But I can tell you, if you see a nerve coming, or any place that's going deep, it's going below muscle, it's not going to be a sensory. It won't be a cutaneous nerve. That would make no sense. It's not going to skin, it's going to muscle. So it's going to be a motor nerve. So 11 gets these two muscles. And know how it acts. All right, so let's see what the next slide is. Here are the two sub-triangles for the posterior cervical triangle. So if you put inferior belly of the omohyoid muscle into place, occipital triangle is going to be the one with trapezius, sternocleidomastoid, inferior belly. Supraclavicular will be inferior belly, sternocleidomastoid, clavicle. Two sub-triangles. Most of what you had to know relative to the sub-triangles will be found in this occipital triangle. A couple of things we can kind of see going across supraclavicular, but this is the primary one where most of the contents, all the prevertebrals, all that good stuff. I'll talk in just a moment, it should come up, about fascia covering this, or what we call the roof, if you will. I know some people have not understood about roof and floor. Basically think about roof and floor like you're looking at it like this. On the head, standing up like this in anatomical position, those roof and floor are really lateral wall, medial wall, but know it as roof and floor because that's how it's listed for you. And make sure you know that. All right, so it was the next slide. So if you look, basically this is a cross section through the head. So this is showing you the space that is the posterior cervical triangle. So this line out here would be, if I go back, it would be basically if I covered where the white, if I have a fascia going from trapezius up to sternocleidomastoid, that's the roof. Then there's some depth into the board, which is where the posterior triangle is, and then there would be a fascia covering these prevertebral muscles. That would be the floor. So the roof is kind of out towards you. The floor is down into the board where those muscles are. And there's a space between what would be those two fascia. Okay? So the roof is formed by the fascia covering these two muscles. That would be the outer investing layer, the deep cervical fascia. And then the floor is going to be the fascia covering those muscles, prevertebral. Yes, sir?
So the prevertebral muscles are deep to the posterior triangle, but we still say they're part of the posterior triangle?
You can see them within the posterior triangle. The answer is yes, because you think about having, I mean, if I went past that fascia, I'm still in what's considered posterior triangle. Okay? I know by that boundary, not so much, but just think of them being part of the triangle, because that's where you see them. Anatomically, that's how we refer to it. In the lab, I'll get to it in a minute, because I want to show you something a little bit further to help you maybe identify the muscles. There's 5 that's there. It's really pretty straightforward. You see, oh, there's splenius, levator, posterior, middle, anterior, but it's a little bit more than what that is. Okay, so make sure you understand the the roof is by outer investing of the deep cervical fascia. The floor is by prevertebral fascia. I think this is getting more about, so inferior belly can be seen in the posterior triangle, anterior can't. While I've got this on there, make sure you understand about belly, omohyoid, both bellies are innervated by ansa cervicalis. There is no difference in innervation. That won't be the same thing when we talk about digastrics in a little bit. I'll talk about infrahyoid muscles later. All right, so here kind of showing you that pattern again. Make sure you know which of these muscles is which, more for lab. Make sure on the lecture part you know these are all part of the prevertebral muscles. Okay, so a lot of questions that I've had in lab have been about these 2 structures right here, the transverse cervical artery and the suprascapular artery. I don't know that I've seen a model that has both those arteries together on it, all right? So I think our ability to tag one of them is limited. I don't believe, and I can say it pretty confidently, we would tag one of these without the other one in place. That said, maybe we put an arterial graft in play. Just know, for these 2 arteries, they basically parallel each other, kind of go in the same direction. Transverse cervical always sits superior, suprascapular always sits inferior. And then the other thing that people have had the question about is, well, what about the suprascapular nerve? What you're looking for, so here's the brachial plexus. When you see a nerve come off of the brachial plexus and goes down and follows this artery, it's the suprascapular nerve. So really also, let's put it into easy terms. There's only one and one only branch of the brachial plexus you would have to know at this point in time. So if you see some nerve coming off the brachial plexus that gets labeled, no matter where it's going to or whatever, what are you going to call it? Suprascapular nerve. Okay? Work smarter, not harder. All right. So I want to get to this view again, even though we're doing posterior neck, let's talk about the muscles. So one thing I've been able to show different people is the easiest thing to do to be able to know these muscles. I mean, oftentimes you start from the back and go down. Start from this direction first. Because what I want you to notice is, and I'll talk more about this when I do root of the neck, but for right now, understand, here's a muscle right here, there's a muscle right here. So this is going to be anterior scalene, this is going to be middle scalene. I always definitively know those 2, because if you look, here's the brachial plexus, here's the subclavian artery. These 2 structures pass between anterior scalene and middle scalene, always, definitively. When I talk root of the neck, I'll say the subclavian vein actually goes anterior to the anterior scalene. These go posterior to the anterior scalene. So always look for the brachial plexus. It's the easiest one to see. It goes between these, so that means this is anterior scalene, this is middle scalene, here's posterior scalene. That's always the hard one because most of these models have multiple slips of muscle, whatever. But we'll say posterior, levator, splenius, and then here's trapezius. Okay? You can start from this way, but on most of these models, there's not 5 distinct little pieces of muscle. Oftentimes there's 6, 7, 8 pieces of muscle. It's hard to tell, especially in this area, which is which. But definitively, you can tell these 2. Pretty much definitively, you can tell splenius. So if you see splenius, right next to it has to be levator. Anterior scalene, middle scalene, because it's got brachial plexus, subclavian artery passing between them. Everybody see that? No reason to miss one of these muscles. That should be straightforward. All right, here's the example that I was talking about for spinal accessory nerve. If you look, here's a nerve that at first glance you might think Now, I know you see all these other things coming out to it or whatever, but if you see a nerve that comes from deep to sternocleidomastoid, it's going to go over and go deep to the trapezius, it's going to be the spinal accessory nerve. Not to be confused with any of the stuff that's brachial plexus or whatever, brachial plexus, cervical plexus. All right, again showing you, remember, jugular vein is internal jug's lateral. Here's the common carotid medial and the vagus nerve kind of posterior between the two. Well, I have this up. Let me see what my next slide is. I'll skip that. Okay, I'll talk about this before we get done. All right, so let's talk about the cervical plexus. Some facts that you have to make sure that you're aware of, because I know some people have gotten confused about cervical plexus itself versus the other components. So when I talk cervical plexus, everybody should know VPR C1 to C4. Everybody's got that down, right? As a plexus, what did we say a plexus was? It's a network of nerves. So this network of nerves has sensory parts and then motor parts. The plexus itself is a mixed entity. It has both sensory and motor. Remember, a VPR is a mixed structure. It has both sensory and motor fibers to it. If you don't know that, go back and look at your spinal nerve drawing, and you see a VPR is mixed. All right? So because of that, there will be sensory components, there'll be motor components to the cervical plexus. All right, so when we talked about it, we said that the sensory aspect of the cervical plexus was in these four named nerves here that we see. All right, supraclavicular, transverse cervical, greater auricular, lesser occipital. Those are purely sensory nerves. Nothing motor about them at all. I know there's a diagram coming up in just a moment that shows their nerve or the dermatome distribution. Know where they're sensory to. I mean, if I touch my clavicle, this clavicular area, supraclavicular, kind of below on the neck, below the chin, transverse cervical, angle the mandible, kind of auricle the ear up here, greater auricular, behind the ear, up towards the occipital bone, lesser occipital. Make it easy. Okay? Those are sensory branches. This diagram shows you, or it'll show you if C2, C3, C4, don't worry about that. I don't care that you know which VPR contributes to which nerve. Just know that the cervical plexus has four sensory branches to it and where they're distributed to. All right. You know that this spot right here is Erb's point. So, here we know supraclavicular, transverse cervical, greater auricular, and then lesser occipital. And where they go to is where they will be sensory to. And then here's another nerve, not really coming out specific at Erb's point, a little bit higher, coming out from deep to sternocleidomastoid, going deep to trapezius. That must be the spinal accessory nerve. While I have this up, it may come up on the next slide, but I'll talk about it anyway. One other thing you need to know relative to sternocleidomastoid is the fact that there's a vein crossing its superficial surface. This is the external jugular vein. I know some of these models have other things like this vein out over here. Don't worry about them. There's only a few veins you have to know for this practical. You must know external jug is superficial to the sternocleidomastoid and that the internal jugular vein is deep to the sternocleidomastoid. Okay, so that gets that. All right, so we said the cervical plexus is both sensory and motor. So let's talk about the motor aspect of the cervical plexus. So we said that motor has a couple of things. One is something called the ansa cervicalis. Ansa cervicalis is formed from VPR C1, C2, and C3. The VPR of C1 contributes to what is called the superior root of the ansa cervicalis. C2 and C3 contribute to the inferior root. And the way you can kind of remember that, instead of just memorizing or whatever, is C1 lies superior to C2 and C3. So it's the superior root. These contribute to the more inferior root that forms this loop, ansa cervicalis. Remember, this C1 VPR is not a part of the hypoglossal nerve. It gets wrapped up with connective tissue in the same kind of epineurium, but it's not part of the hypoglossal nerve. It's from C1 BPR, and then it just hitchhikes along. Some of the C1 axons will go to the superior root. Some of them will continue on along and go to this C1 nerve. This motor aspect that we're looking at here, ANSA and the C1 nerve, provide motor innervation to the muscles of the infrahyoid group. ANSA cervicalis gets 3 of the 4. ANSA's motored all the muscles of the infrahyoid group except for thyrohyoid gets its innervation directly from the C1 nerve. So sternohyoid, sternothyroid, thyrohyoid, innervated by ANSA cervicalis. Any questions about the cervical plexus? Everybody's an expert now, right? Yes, sir?
Does C4 contribute to the inferior root?
C4 does not contribute to the inferior root, because first off, you would know, where does ANSA cervicalis come from? C1 to C3, so the answer has to be nope. Now, I know that you all know at this point that C3, C4, C5 go to the phrenic nerve to keep the diaphragm alive. So basically, if you destroyed, I'm not even going to go there. Next exam, maybe I can say, if you destroy all aspects of the cervical plexus, what nerves might be affected? Obviously, all aspects of the cervical plexus, these 4, I would definitely affect the phrenic nerve. I still have a little bit of functionality, because C5 would still be functional. But that's next exam. Yes?
So the phrenic nerve is part of the cervical plexus then?
My answer is yes and no. Obviously, it gets contribution from the cervical plexus, but not all of it comes from the cervical plexus. How about if I say it like that? For your part, I really want you to know the motor part of the cervical plexus is ANSA and C1. We talked a moment ago about Erb's point. You know, it's the point posterior to sternocleidomastoid where the 4 sensory branches of the cervical plexus exit, come out around, and go to their distribution areas. Okay. So make sure on this slide you get a feel for the distribution areas for those different nerves, just like it shows on here. All right, so I already mentioned about external jug and internal jug. External is superficial to sternocleidomastoid. Internal jugular is deep to the sternocleidomastoid. Don't worry about, at least for external jug, where it's going to, what's draining, all these different veins. And internal jug, you do need to know what's it going to do. It combines with the subclavian vein to form the brachiocephalic vein. That's more for thorax than anything else. Here's another picture demonstrating the 2 arteries. So you know this one that lies more superior would be transverse cervical. The one that lies inferior is going to be suprascapular. And again, you're going to see a nerve that comes off the brachial plexus to go follow that artery. There would be where the suprascapular nerve would be. If I'm a betting man, it won't pop up on Wednesday. Yes, sir?
Could you say that again?
Suprascapular artery lies inferior, transverse cervical superior. Again, if you see a branch coming off the cervical plexus, on this slide right here, you don't even know where it's going to go to. But if you see a branch off the off the brachial plexus and get labeled, what are you going to call it? Suprascapular. Suprascapular nerve will follow the suprascapular artery to go back to the suprascapular region of the scapula. Okay? Anything off the brachial plexus. Man, maybe somebody labeled this thing. Call it the suprascapular nerve. It's the only nerve you got to know off of this thing. Okay, anterior cervical triangle. So here's the area of its distribution, or where it's located at. Whoops, sorry. I thought it was labeled on this. It must be next lecture. Anyway, so here's anterior cervical triangle. So its roof, again, is by the outer investing layer of the deep cervical fascia. Its floor is going to be by the pretracheal fascia, and then you say a little bit by the carotid sheath, if you will, however you want to do that. But roof, outer investing, floor, pretracheal, carotid sheath. So make sure you know there are 4 subtriangles of the main anterior triangle. Again, anterior triangle itself is by sternocleidomastoid, the mandible, midline of the neck. So kind of not arbitrary, but it's not a real structure, if you will, in a way. And then we use multiple things to help subdivide into the subtriangles. So some things that come into play will be things like the superior belly of the omohyoid, and then the 2 bellies of the digastric. All right? So these with the mandible kind of forming submandibular, posterior belly, sternocleidomastoid, omohyoid, superior belly forming carotid triangle. Submentals, the 2 anterior bellies with the hyoid, and midline of the neck is more omohyoid, sternocleidomastoid, midline. Just however it's written in there, make sure you know them. So another view showing you the 4 triangles. Okay, so list out the muscles or structures, whatever it may be, make sure you know them. When it comes to contents, there's a list on each of these that kind of shows it. I don't get into usually typically a big deal about those. Carotid is the one you typically want to really know. You can imagine something like submental, submandibular, submandibular gland, facial artery veins, things of that nature. Muscular, infrahyoid muscles, viscera of the neck. So kind of go through that and you'll be all right. Again, know the carotid. You're going to make sure that you know that the carotid sheath contains just those 3 structures. Ansa cervicalis is not part of the carotid sheath or a content inside the carotid sheath. This is where we get into semantics, and the class lawyers will always get into the aspect of, well, it's in the carotid sheath. What do you mean by inside the carotid sheath? So obviously I'm not going to write a question where that's going to come into play because I don't want to have to sit and discuss inside versus within. Sounds like the same thing to me. Yeah. So it's probably right when writing test questions, Okay. Carotid sheath. Make sure you know lateral, medial, posterior. Let's see, there's got to be. So there's 2 things about this. Make sure that you know that the common carotid splits into, or divides, branches, whatever, into the internal and external carotid at the level of the laryngeal prominence, Adam's apple, if you will. Okay, one other really good fact to know is, and I know people have gotten confused relative to the laryngeal nerves. All right, so let's kind of go through those. Hopefully I'll have a picture in a little bit that we can show lab-wise as well. So if I am a laryngeal nerve, I must somehow be related to the vagus nerve, no matter which one I am, okay? Directly or indirectly, I have some relationship to the vagus nerve. There are 2 branches that come off that are directly from the vagus nerve: superior laryngeal, recurrent laryngeal. Those come off directly from the vagus nerve. As they come off, they are mixed nerves, sensory and motor. What happens with superior laryngeal? It divides into internal and external laryngeal nerves. Recurrent, it recurs, it loops back up. Recurrent, all you have to know right now about it is location in the tracheoesophageal groove, and I'll show you that in just a moment. The other thing I want you to know, very important, is this aspect right here, the 4th bullet on this slide, about the internal laryngeal nerve. What does it do and who does it travel with? The internal laryngeal nerve travels with what's called the superior laryngeal artery. And they both will pierce through the thyrohyoid membrane to go to the larynx. It's a fact you just got to know. I mentioned it was a board exam question. I've stressed it, made a big point about it, so you probably want to know something about it. Okay? Internal laryngeal nerve. I don't even care at this point that you know it's a purely sensory nerve or whatever. I want you to know we'll get into that when we do larynx. What I want you to know is it's a branch of the superior laryngeal nerve. I want you to know that it travels with the superior laryngeal artery, pierces the thyrohyoid membrane. Okay, so while I've got this here, let's do a couple of things with this. It comes up on the next slide thing too. So here is our good friend, our good new friend now, common carotid, and then external and internal. So here is the laryngeal prominence. So basically about that level is where we say it splits, common carotid, into external and internal. People have asked me about one being more anterior, posterior, one being more lateral or medial or whatever. The easiest way to know it in here, if nothing else, is the fact that, what do we say? This one has branches in the neck. This one does not. If I see, should almost always see this superior thyroid artery, I know this is going to be the external carotid. The one that's more posteriorly located is going to be the internal carotid. No branches in the neck. 5 cervical branches. Some people have asked me about these branches up here of external carotid. That's for the next exam period. Don't worry about them for now. People have looked ahead and have learned what these are. Don't care. 5 cervical branches you got to know. If you look, here's thyroid cartilage. Here's the highway bone. There's a membrane right here. No, look, there's a little artery piercing through that membrane. What must this artery be? Superior laryngeal artery. What should we see following with it? Internal laryngeal nerve. And what should this thing be a branch of? That right there is superior thyroid artery. Remember, 5 direct branches of the external carotid in the neck. There's another artery, the superior laryngeal, that's a direct branch of superior thyroid. So it is not a direct branch of the external carotid artery. It's a direct branch of the superior thyroid artery. Okay? All right, so what are the 5 direct branches, cervical branches of the external carotid? And I don't worry so much about in order, but it kind of helps you to identify them in the lab, kind of thinking about them in a certain order. Typically, about the first one that should come off, but the only one that travels down, goes in an inferior direction, will be this right here, the superior thyroid artery. Because where's it going to? The superior part of the thyroid gland. Here is the superior thyroid artery. All right? It also has the little superior laryngeal artery as a branch of it. Then, when you work your way up, the next one you should see should be lingual. And it's only going to be a small little piece that comes across and then it disappears. So look for lingual next, then work your way back up and going anteriorly. Next you come facial. You'll always know facial because if you follow it, it's going to go over the submandibular gland, go behind the mandible, and then come back up and go up onto the face. You should be able to see most of that pathway for this artery, facial artery. Then almost at the same spot, number 4 will be this artery. It's the only one that's going to travel in a posterior direction, going back to the occipital bone. So here is the occipital artery. Now, oh shoot, I can't do it on this. I was going to move the label. Let's see if All right, so one other aspect that I want to point out about this is, if you look here at the occipital artery, look, there's a nerve right here, and as you follow the occipital artery around, basically the hypoglossal nerve and occipital artery kind of wrap around each other. All right? So it helps you identify both the artery, of course it's the only one that's going posteriorly, and the nerve. You see a nerve that this artery kind of wraps around, as I say, has an intimate relationship with? Hypoglossal nerve. All right? So that's 4 of the branches. The 5th one is the hardest one to see, and it's the one, the only model I've seen, and maybe it's on more, but on that B4 model, it's one that you can see, not easily, you've got to find it. But if you look, here's external carotid, here's internal carotid. So between the two, on kind of the posterior aspect of the external carotid, there's a branch right here that exits off and then travels straight up. Kind of the same pathway these 2 big arteries are going. This is the ascending pharyngeal branch. Now, one last thing that people tend to not pay attention to and they kind of forget about, what if we labeled, it's like at this point where there's facial, occipital coming off, there'll be an artery right in the middle. What is this? External carotid. What if you tagged right here? External carotid. So remember, external carotid is fair game as well. So if you tag right in the middle, so here comes facial, occipital, and then, oh, what's this? Oftentimes people are still trying to think of another branch. It's the external carotid artery. Don't lose forest for the trees. Okay? Let's see if there's anything else off this diagram that I want to show. Now I did it like I should. Okay, so that should have got most of the stuff through posterior triangle. That, oh, and on some of the models, I know this was a lab quiz question. So if you look, here is the carotids. So there's a structure running right here along with it. Okay? I know it looks like there's a couple things. I'm not going to talk about the other one. But you don't see the vein in place here because it can be out lateral. It would be really large diameter. Don't go by size, is what I always say. But typically when you're looking posterior to the carotid, what structure should be posterior to the carotid? The vagus nerve. Okay.